will
Yeah.
have the open first.
Good afternoon, everyone. Dear colleagues, it is my pleasure to welcome everyone to the second day of our second online seminar series about addiction medicine for general practitioners. I am Dr. Evelyn Wijaya, a research assistant of Psychiatric Department of Atmajaya University. I will be the host for today's session. And we'd like to extend our special welcome to our guest of honor, Albert Batalla Cases, MD, PhD, who will be our guest speaker today. Dr. Eva Suryani, a psychiatrist, as a committee chairman of this seminar, and Atmajaya Collaboration, First Windsor, North Netherlands, and University Medical Center Utrecht, who support this event. We're so glad to have you all today to learn together about the addiction medicine. Last week, we have discussed about cognitive behavioral therapy with Janika Heitman, PhD, and today we will discuss more about psychosis and addiction. Today's agenda will be guest lecture from Albert Batalla and discussion session, and followed by closing remarks from Dr. Eva Suryani. And here's some event information for you before we start our agenda. Okay, so expert lecture will be presented in 60 minutes and will be followed by 45 minutes discussion. And participants could ask questions in the chat room, or you can raise your hand if you want to ask directly to Albert Batalla. And also participants could also see online seminar through YouTube channel, Atmajaya YouTube official channel. And also how to get e-certificate. So e-certificates are only given to participants who has filled the registration and pretest before each session, and also post-test with pass limit value 80, and it can be repeated if you haven't reached the pass limit value. And the post-test link will be given at the end of this event, and the link will be closed at 12 a.m. midnight, West Indonesian time each day. Okay, before we enter the main agenda, let's have a poll to know our participants more. If you could see on your own screen, please choose and click one answer, and we will see the result together. Okay, we have got the answer from the participants. So there are 83% who have ever met a psychosis patient with addiction, and the most often used substance in patient with substance use disorder is stimulant, and followed by alcohol, cannabis, and nicotine in the second, third, and fourth place. And now let's enter to our main agenda. I would like to invite Dr. Durotol Ikrimah as moderator for today's seminar to read the CV of our guest speaker and lead the session. Please, Dr. Duroto.
Thank you, Dr. Evelyn. Sorry. Wait a minute. Okay. So good afternoon, everyone, colleagues, Dr. Eva, Dr. Evelyn, and also our honored guest speaker, Dr. Albert Batalla, PhD. It's a pleasure being a moderator today, and after 4 sessions in this seminar series, which are all very interesting indeed, we have arrived in the last topic about one of the comorbidities that also arise from substance use disorder, which is psychosis. So today we would like to learn from our guest speaker, our expert who has focused on this topic in the past years, the relation between early psychosis and also substance use disorder, particularly with cannabis use. So I would like to read his CV. Dr. Albert Batalla, PhD, completed his Bachelor of Medicine and Surgery in 2007 in Autonomous University of Barcelona, Spain. And he also completed his residency there and started to became interested in cannabis use and psychosis. He started his PhD in 2011 in University of Barcelona. And after that, he moved to Netherlands, joined NISPA, Nijmegen Institute of Scientists and Practitioners of Addiction, and Radboud University Medical Center as a lecturer and also psychiatrist. And now he works in University Medical Center Utrecht, and now also as a psychiatrist and also a researcher. Before we start, I would like to tell all participants that we will have 60 minutes of very interesting and interactive lecture from Dr. Albert, and will be followed by 45 minutes discussion sessions. So for those of you who wants to ask questions, please feel free to drop your question into the chat box. And without further, I would like to invite our guest speaker, Dr. Albert Batalla, to give his lecture now. So welcome, Doctor.
Hi, hello everybody. Thanks for the kind introduction. I'm really happy. It's an honor to be here. So I'm really happy that you invited me to talk about a topic that I really like a lot. That is the comorbidity addiction and psychosis. And that's why I work what I work. I work in the Netherlands, indeed, at the UMC Utrecht Hospital. And what I mainly do, I work in the early psychosis unit. So I work mainly with young people from 16 to 40 years old who experienced for the first time a psychotic episode. And I'm specialized in drug use. So I see that most of these young patients, or not that young patients sometimes, also use drugs. That is really often. And well, that's why I'm really interested in this also in my research. And I focused mainly on cannabis, but of course also I pay attention to all the drugs that are also really common and really important. And yeah, well, as you already mentioned, I'm also involved in teaching activities, and I work at the Radboud University in this. So I'm involved in what we name a master in addiction medicine. That is the master that the doctors have to follow to become an addiction doctor. So here in the Netherlands, they have this kind of specialty. So you can become, after medicine, you can become an addiction doctor. So a doctor specialized in drug use. And besides, you have, of course, psychiatrists, like I am. Okay, so that's a short introduction of who I am.
It's different from residency program.
Sorry, what did you say?
So it's different from residency program.
Yeah, it's different. So here in the Netherlands, you can follow the residency in psychiatry. So then you become a psychiatrist. And within the residency, in some countries, not in the Netherlands yet, but in Spain, for example, you can subspecialize in addiction within psychiatry. But here in the Netherlands, they do have a special training, not for psychiatrists, but for doctors who want to become an addiction doctor. So they see and they treat addiction. And then when there's also a psychiatric comorbidity, they call us. So then we work together with them to treat most complex patients. I'm not able to share my screen. I don't have the rights. So maybe you can give me the rights, and I'll share my screen.
Yes, how about now?
Yes, now I can, thanks. Now I want to spend more time in the introduction, because otherwise we wouldn't have time to talk about what's important. So that's the what I think is important. Talk about this comorbidity. So I try to keep within 60 minutes. I'll do my best so that we have time of discussion. But I have to say, this presentation also has cases embedded inside. So I also expect your participation during the presentation, and I'm also happy to take questions during the presentation. I like that, so that's not a problem at all. And when you see a question on the screen, you can write this down. I think you can see my mouse moving here in this link. If you write this link in your browser, whatever you use, doesn't matter, then you'll be able to answer the questions online. So that's beside Zoom, let's say, so that you need another browser to open another browser and write this link down. Okay, what I'm gonna talk today, what I would like you to hear from this lecture, to learn from this lecture, is the following. So I divided the lecture in 5 different blocks. So the first, I'll provide you a short introduction about more epidemiological facts about the use of drugs in people with psychosis. The second, we'll discuss aspects about the curse and the influence of drugs during psychotic episode. And the third block is related to neurobiology. So, and I'll see how deep into the neurobiology we want to go. So probably I'll skip this a little bit, because I think you will be more interested probably in the treatment. So how do we have to treat patients that experience psychosis and also uses drugs? So that's complex. It's a complex thing. So probably I like to spend some time here in the treatment options. So let's start with the introduction, and I'll start right away with the case. All these things, all the cases that I present here are real. So these are just real patients that were admitted in our unit in the last time. And this patient was a 20 years old American student who was actually in the Netherlands because of his study. So he was here already 2 months living in the Netherlands, and he was admitted to the hospital because he suddenly started experiencing 3 days ago. So really suddenly, in a short period of time, he started experiencing paranoid and reference delusions. And he was actually mainly disorganized. And so his thoughts were disorganized, and his behavior was completely disorganized. And there was a reason that his friends brought him to the hospital. And then, well, we saw him, and when we did some research on him, and we explored him, and we saw that he had increased energy, that he was not sleeping at all, that he was indeed disorganized. He didn't have any hallucinations, so the perception was actually okay. The mood was also neutral, so he was not experiencing mood alterations. And he told us, well, that he was a regular smoker. So he smoked cigarettes since a long time, but also he was using cannabis since he was 15. So that's already 6 years ago that he started. And he told us that in the last weeks, he was just smoking as he always smokes, and he was using cannabis at the same rhythm that he always does. So nothing changed. And he said, well, I didn't use other drugs, so I just kept on using cannabis in the same way that I did. Indeed, we controlled the urine for drugs, and he was only positive for cannabis, so the other drugs were negative. And we only know that in the family history of this patient, he had a 3rd-degree relative with a bipolar disorder. So that was everything. So with this information, I would like you to try to answer this question. That is the following: is which factors do you think that contribute to the onset of first psychotic episode? So this patient was experiencing for the first time psychosis. And question for you is, okay, was cannabis involved? Is the fact that he was staying in the Netherlands, the family history, only A and C, so staying in the Netherlands is not relevant, or you think that actually all of them are important? So you can vote. I see already some people voting, so that's great. It works. I'm really happy with that. All right, 8 people voted for. I think 25 people can vote. So I don't know how many people do we have listening today, but so you gotta be fast if you're going to vote. If we have more than 25 people, because only 25 people can vote. Let's see, 9, 10 people already voted. Okay, I see that most of you for now think that A plus C is the option. Some of you also thought that all of them. Well, it depends a little bit. I have to say, I'm really happy to see that cannabis is, of course, a factor that influences the use of the onset of psychotic episode. Also, the family history, that's really clear. And staying in the Netherlands might also be a factor that might influence, might induce a psychotic episode. And the reason is that when you live abroad and you are not with your close relatives and you experience that you are in a minority position in a society, that might provide you and may give you a stress, and this stress might also contribute to a psychotic episode. But I understand that some of you didn't vote this, because that's the question, whether that was the case in this patient, because actually this patient was really good integrated here in the Netherlands. So he had a lot of friends in these 2 months, had a lot of friends. He was quite integrated in society, also with a lot of American students. So that's the question, if he was experiencing with kind of stress of because he moved abroad, but that's something that can also play a role in psychosis. It's that's not weird at all that you said that all of them might have contributed to this psychotic episode, and that's something that we know from the literature. If we look to the models that try to explain why some people develop a psychotic episode, most of the models they use this kind of figures, right? So they say we have people with a certain genetic vulnerability. So you were born with certain genes, and that determines your morphology, your functionality of your brain. Some people may have a certain vulnerability, and if you get in touch with certain social stressors or certain environmental factors, then some of these people will progress and will develop a psychotic disorder because of alterations in several neurotransmitter systems, networks, or whatever. Some of these people will. But on the other side, if you have enough resilient factors, so if you have enough protecting factors, you may also not develop a psychotic episode, even though you have this genetic vulnerability. So the environmental factors in combinations with the genetic background of someone is what determines that some people will develop a psychosis and others don't. And here you see that the use of drugs is a factor that is related to the onset of psychosis. So people who use drugs in general, they have more chances to develop a psychotic illness compared to those who do not use drugs. And what's important also about the use of drugs is that this factor, or the influence of this factor, is actually double, because the use of drugs is involved in the onset of the psychosis, yes, so that's pretty clear, but it also influences the course of the illness after the person developed a psychosis, and actually negatively influences the course of the illness. So we have both. It's involved in onset, but at the same time, it also influences the course of illness, and actually, it's quite negative. I'll talk about this a little bit later. If we look at the prevalence numbers, so how many people actually use the drugs? For people with psychosis, how many of them are actually using drugs? So we see that the comorbidity is really high. So if we compare patients with psychosis to those without, we see that people with psychosis actually at 2-4 times, they use drugs 4 or 5 more times than expected in the general population, and that's really a lot. And the most used drug in people with psychosis is tobacco. So the use of nicotine is the number one. So I was a bit surprised of the poll, because I saw a lot of using patients with psychosis and stimulants, it's also a pretty common comorbidity. But nicotine use disorders are for sure the number one. After that, we see alcohol and cannabis use, and after that, stimulants. So I wonder why, I don't know, I didn't check the numbers in Indonesia, but it's possible that the use of stimulants is much more common there than here. Maybe someone of you can comment later on this, but I found it fascinating. Here in the Netherlands, we see mostly most of people with psychosis, they are smokers, so they use nicotine, and secondly, cannabis and alcohol are the most common comorbidities in these patients. And also really interesting is that if you look at the whole course of the illness, in this really huge longitudinal studies involving a lot of patients with psychosis in Europe and America, you see that almost the half of them experience. Sorry, I'm being called. Sorry about that. I gotta stop my phone. That almost the half of them experienced had a substance use disorder sometime in their life. So that's really a lot. And that's, of course, excluding nicotine, because if you tell also nicotine use disorders, you reach this kind of 60-90% of the population. So that's really a lot. Of course, these numbers are not always and everywhere the same. So you have a high heterogeneity between the groups. So because it depends a lot where are you looking. So if you look at inpatient units, for example, here in the Netherlands, if you look to inpatient units where you have more severe patients, you can see that the prevalence of substance use disorder is much higher compared to, for example, some outpatient units. And also depends on what kind of psychosis, of the severity of the psychosis. You see also some differences, right? At what time of the course you are. But in general, so I want you to have an idea. In general, what I want you to know is that prevalence is really high. So the use of drugs is actually rather the norm than the exception. So most of them will use drugs sometimes. And that's important because that is something that may influence the course of the illness. And well, as I said before, I do a lot of research in cannabis. Because cannabis is a really interesting drug, because from the cannabis you can develop psychotic symptoms that resemble a lot to psychosis, but at the same time, cannabis is a really complex plant and is composed of several cannabinoids, right? So the most known cannabinoids, probably all of you know this, is THC. THC is the bad guy, right? THC is the pro-psychotic component of cannabis, so you can get psychotic from it, and you can also get addiction from THC. But cannabis has also other components, such as, for example, CBD. I don't know if you're familiar with this, but in the Netherlands, CBD is pretty popular stuff. Right now, you can buy it almost everywhere, separate from cannabis. And that's interesting because there are some studies in the world popping up showing that CBD may have somehow antipsychotic properties. So that's something interesting and somehow a bit shocking sometimes, because that means that in the cannabis plant, that might be components that may help against psychosis, but we know that there are also components that are really bad for psychosis, such as THC. So that's quite interesting. So I'll skip this question because I already answered it for you. So the CBD is a component in the cannabis plant that may have antipsychotic properties. But what I wanted to show you is that how is the reality actually? If we look in the whole world, what happened with the concentration of THC in the last years, so you see that the cannabis that the people are using now has nothing to do, is not even close to the cannabis that people was using in the 80s. So here, so in the 80s, so the cannabis maybe my grandparents were using, I don't think they did, but so the cannabis that they were using in the 80s, there was about, they had about 2% of THC, so really low THC concentration. But the cannabis that you can find now in the Netherlands and in a lot of places in the world has THC concentrations around 10% or 15%. So that's really a lot. So that's a huge difference, and that's something important because these differences in the potency might also involve more people developing psychotic symptoms and more people developing psychotic illness. So that's why this is really important, and that's a phenomenon happening worldwide. And if you ask me, okay, and then but how many, how much CBD contains this cannabis? Because I said, well, cannabis may have also CBD, so kind of positive stuff, you know, helping against psychosis. Well, the answer is that the most common cannabis that we can find here in the Netherlands, so high potent cannabis with a lot of THC, it contains almost no CBD. So the CBD concentrations are like less than 1%. So it's really, really low concentration. So this protective effect of cannabis, if that exists, is something that we cannot see anymore, because the cannabis that people use in the world are really high concentrated in THC. So the concentrations of CBD are really, really low. And that's because if you grow a plant, a cannabis plant, and you try to get a lot of THC, that is because the other cannabinoids get less and less and less. So you get plants with a lot of THC, but then much less of the other cannabinoids. And that's also true for CBD. So, well, that's bad news in the sense that because of it, that there may be a reason that more people can become psychotic because of the use of these cannabis plants. Okay, I hope that was clear. First block, that was just the introduction. So then I like to move to the course of illness, which is something that I already mentioned a little bit, but I like to explain a little bit the ways that we have to define the relation between the use of drugs and the onset of psychosis. So if you want to describe this relation, okay, what's the relation of using drugs and then having a psychosis, you can do this in several ways. So you can say there's a causality, so a cause-effect relation. So people who use cannabis will become psychotic, but that's not actually true. So we cannot talk about causality because, fortunately, not all the people who use cannabis will become psychotic. And that's really good news, because in the whole world we do have a lot of people using cannabis, and most of them will not develop a psychosis, but some of them they will. So we cannot really talk about causality, because we see that if you use cannabis, you have an increased risk to develop a psychosis, and the risk is between 2 to 5. So you get the odds are 2 to 5 higher if you use cannabis compared to those who never use cannabis in their life. So you get more chances. So why is that? Then, as what I said before at the beginning, so most of the most relevant theories right now, they say that's probably because of certain genetic vulnerability. So some people may have kind of special sensitivity, and if they get in touch with cannabis or other environmental factors that are related to psychosis, you see them here below. If you get in touch with these factors and you have this vulnerability, then you will get more chances to develop a psychotic disorder. So that's another of the theories, right? So that's the second one. But there are other theories, more complex to test, that say, well, maybe it's not. Maybe the genes that are involved, that give you vulnerability to develop a psychosis, are also the same genes that also give you more chances to use cannabis. So a kind of shared genetic vulnerability, so that because of your vulnerability, you have more chances to develop a psychosis, but also you have more chances to use cannabis. So it gives you with more sensitivity to start using cannabis in the first time. And the last of the theories is the self-medication theory. So these theories, they say that it might be actually the way around. So that people with psychosis, having a psychosis, are more prone to use cannabis because of the fact that they want to cope with the psychotic symptoms, or they want to cope with the adverse events related to the medication that they use for the psychosis, right? So that's another theory. But as you can see here, the arrow is a bit smaller, and that's because this theory is not supported by all the authors in the literature. So you'll see a lot of discussion about this, because if you look at the studies and you look especially at the reasons why people with psychosis use drugs, actually the reasons that they tell are exactly the same reasons that people without psychosis using cannabis also tell. So actually there's no difference at all. And the reason that some people may keep on using drugs, even though they experience a psychosis, that may be related to the addiction itself. Because if you develop an addiction, so you know it already, right? Because you had lectures, I think, about the neurobiology of addiction. You lost control of yourself and you keep on using drugs, even though you know that that's not good for you. That's something that may happen also, of course, in people with psychosis. So people with psychosis may become addicted and they will keep on using drugs because of the addiction, right? So that's really difficult to differentiate. And that's why this arrow here is a little bit smaller compared to the other one. But probably you will see patients in your regular practice that also say to you, well, I use drugs because they help me with whatever. With the voices that I heard, of because of the negative symptoms that I have, but most of the patients will use because of the pleasure that they experience with cannabis, and because of an addiction, an underlying addiction that they may also have. All right, and then I said, well, just the odds, right, are like are quite huge, but the range is pretty huge as well. So like you have 2 to 5 times more chances to become an addiction. Why is that? What's determining this? So we think there's literature showing that these factors, so the way that you use, is also really important to these chances. So you will get a higher risk to develop an addiction the younger you start using, the more potent the cannabis is. So the potency of the cannabis is really important. So the more THC the cannabis has, the more the chances you'll get to develop a psychosis. And also regarding the exposure, the longer the exposure, so the more you're exposed to the cannabis, the more the chances you'll get to develop a psychotic disorder. So this is why the odds are so. This has this so big range between 2 and 5, because the way that they use drugs are also really important in the chances that you have to develop a psychotic disorder. This is a really nice, interesting study showing the importance of the potency and the importance of the exposure. That's a nice example. This is a study performed in the UK. In Europe, and what they did, these were patients admitted for the first time with a first psychosis, with a first psychotic episode, and then the researchers asked to the patients if they were using cannabis, yes or no, and if they were using cannabis, how much were they using and what kind of cannabis they were using. And what the researchers saw, it's really interesting. You see that the more cannabis the subject used, and the more potent the cannabis had, the skunk is a high potency cannabis. It's a cannabis with a concentration of THC around 15% approximately. So the more cannabis the patients used and the more potent the cannabis was, the earlier the start of the psychosis. So this is the age of onset of the psychotic symptoms, that you see that the more the cannabis they used and the more potent the cannabis was, the earlier the symptoms started. So you see here that cannabis probably is acting as a kind of trigger of an underlying vulnerability, of an underlying psychosis, because of the cannabis use is triggering and is starting maybe earlier than it was supposed to. So that's why the use of cannabis is it might be so detrimental for the patients. And of course, all of you know that experiencing psychotic symptoms is never good. It's never that good. So, I mean, the most of people, they do really experience bad feelings with it. And of course, the earlier you start with the symptoms, the worse it is for your outcome. Because and the later you start, the better. Because of course, the older you are, the more chances you had to develop yourself as a person, right? So the more chances you had to finish your studies, to develop a big network of friends and family. And the younger you are, the less chances you had to develop this. And then a psychosis can be really disrupting of your life. So of course, you don't want this. So using cannabis, it might trigger a psychosis, and make this presents earlier than it should be. So that's not a good thing. And as I said before, you can also see in this slide that after the first psychotic episode, if the patients keep on using drugs, that's never positive. So I've been not able to find any studies saying that keeping on using drugs is positive for you. So all of patients will experience negative outcomes. And here you see the most important ones. So the chances of relapse, of the severity of the symptoms, the hospitalizations, the aggression, suicide, having morbid mortality is much higher in those who keep on using drugs. Also, the compliance with medication is also lower in those who use drugs, and also the functionality and the quality of life. We have some data we are about to publish with Sweden and Finland, two countries here in Europe. And they have this really huge data sets with a lot of patients with psychosis. And we saw in this data set that people with a psychosis that also have a substance use disorder, they have around so the odds ratio is like 2 times more to die compared to those who are not using drugs. So that's really a lot. So it's like if you kept on using drugs, that is only about surviving. So you get more chances to die. Not only more chances to be hospitalized and worse psychosis or whatever, they also have more chances to die because of all the comorbidities that are associated with the use of drugs, the somatic comorbidities, I mean, associated with the use of drugs. Okay, let's go to the case again, to this patient that I told you before. And so the patient, as I already said, he was using regular cannabis, 1 or 2 joints a day, and he didn't use other drugs. What happened when he was admitted after a couple of days, he told us actually that he doesn't have any problem with cannabis because he was just only using 1 or 2 joints a day. So that's quite normal, he said. And actually he said, well, in the past, I used to use more. So I'm really happy because I used to use like 3 or 4 joints per day. But in the last year, I could reduce this to 1 or 2. So I'm really happy. So I tried also several times to stop. He said to us, I tried to stop several times, but I could not, because if I stop using cannabis, I cannot sleep anymore. And then I have to keep on using it because of that. And then, well, what happened is that he moved to the Netherlands. He already 2 months ago, as I told you before. And when he came here, after 1 week of not using cannabis, what happened was that he could not sleep anymore. And that was the reason for him to start using cannabis again here in the Netherlands. And his girlfriend, who was also with him during the admission, he pointed out that during that week that he was not using cannabis when he came here from the States. He was quite angry and quite irritable that week. So she was actually somehow happy that he started using again, because he was, like really angry sometimes. Okay, so after that, in the admission, so we explained to him, right? So we explained to him about the relation cannabis and developing psychosis, and he said to us, okay, that I understand it. I'm gonna stop using cannabis for good. I don't want to use cannabis anymore because I know that I can get psychosis from it. So I want to stop using cannabis. So that comes my question for you. I don't know if you use the DSM-5 that often. It's not that I'm really a fan of the DSM-5, but it's something that we use in the Netherlands to classify patients, to classify patients and give diagnosis. So that's why I ask you if we can talk about the substance use disorder according to the last version of the DSM of this American book, or not. I'm not sure. Maybe you can comment of this. Someone of you can comment on this. Are you using the DSM-5? Oh, not really, because if you're not using it, we can better skip this.
Yes, we use the DSM-5. Yes.
Okay, then okay. If you use it, then I'm gonna I'm gonna ask this to you guys. So can we talk about substance use disorder in this case? Yes or no? So think about that. So I give you several options. So option 1 is yes. So we can talk about a substance use disorder. We can talk about a mild cannabis use disorder, or yes, the patient has a cannabis dependence. Third option is yes, the patient has a moderate cannabis use disorder with the information that you have. It's not a lot, but try to classify him. Or no, in this case, we cannot talk about a substance use disorder. Okay, 4 persons already voted. Nice. Come on, only 4 people. you don't know it. Maybe you're like, it's a tricky question. Nobody else want to give it a try? How many people are listening? Do you know that? Just to get an idea how many people will vote. Okay, I see more numbers. 7 people already voted. Well, that's nice to see. Always, it happens always the same. It's not about you guys, but always that I ask this question, whatever I am in the world, giving this talk, it's quite impressive to see that the differences in the answers are quite incredible. And that's because how the DSM works. It's not clear enough, I think. But well, whatever. Most important thing here is, okay, why we cannot talk about cannabis dependence, because in the DSM-5, the option doesn't exist anymore. So we do not talk anymore about dependence in the DSM-5. So we talk about a substance use disorder that may be mild, moderate, or severe. So the option cannabis dependence is still growing at the time that I'm saying this. It's not an option. So we cannot. So the second one is not correct. Then we can discuss, and I'm happy that also most of you see that it might be an underlying substance use disorder, and we can discuss if this is a mild or if this is a moderate substance use disorder. But in the case description, I hope you already saw 2 of the criteria that you need to diagnose someone with a substance use disorder, and the criteria that you could probably read in the case or understand in the case is that the patient already had several cut down attempts and he wished actually to stop, but he did not succeed. So that's one of the criteria. And the other one were the withdrawal symptoms at the moment that he moved from the Netherlands to from America to the Netherlands. He was angry, he could not sleep anymore, and these are withdrawal symptoms that people experience when they stop using cannabis. These are the most common symptoms that people experience. So if you have someone who already experienced withdrawal symptoms and trying to stop and not being able to, you can, with these 2 criteria in the last 12 months, you can already diagnose someone with a mild cannabis use disorder. And this is important because even in this person with especially in this person with a psychotic episode, because the use of drugs might be involved in the onset of his symptoms. So you have to talk about this with the patients. You have to talk about the importance that he actually has to stop using drugs. And he said already, I want to stop. And that's really good, and I believe him. But you know how it works with addiction, right? So some people really wish to stop, but they are not really able to. So that's why you have to keep on asking this and evaluating this and monitoring this in the next months after the psychotic episode. So you don't have to forget about cannabis use or about the drug use. You have to keep on asking, because it might be involved in the psychosis, in the psychotic episode that he had. So it's an important factor for him to keep on monitoring. All right, guys, that was the second block. So we can, if you don't have any questions or really important questions at this moment to answer, to ask, then I'll move to the next block. And the next block is about neurobiological aspects, about addiction in psychosis. So I wanted to tell you a couple of things. So there's this paper published in JAMA Psychiatry recently, who already is a good summary about the hypothesis that I already mentioned to you, and how we understand psychosis at this moment. And this is already what I said. So we have probably some people with a kind of genetic vulnerability, and then if you get in touch with certain environmental factors and that provide you with stress, at some point you may develop changes changes in your brain that may be related, may trigger the psychotic symptoms as we know them. And one of the most known hypotheses trying to explain the psychotic symptoms are the dopamine hypothesis. So probably you've heard already about this because there's a lot written about this. And but I want to say here that this is actually one of the hypotheses trying to explain the origin of psychotic symptoms. But if you look into the literature, you will find also a lot of other hypotheses trying to explain what molecular mechanisms are going on in the brain of people with a psychosis. Not only dopamine, but also you will find theories about inflammation and theories about glutamate. And I could spend actually like more than 1 hour talking about one of these specific hypotheses. And then this, of course, only with psychosis. If you also try to talk about those with a substance use disorder, with a comorbid substance use disorder, then the complexity grows up. So today I will not talk about all the theories. That's not possible. So we do not have the time. I like to go later a little bit in depth here in the dopamine hypothesis and trying to correlate this with a substance use, with the changes and the brain changes after using drugs chronically in brain. But before that, I want to move to another mechanism that is also probably involved in the onset of psychosis, and that is the endocannabinoid system. And I wanted to talk about this because you will probably hear much less about this hypothesis. So if you go to lectures about psychosis, you hear a lot about dopamine and inflammation and glutamate, but you will not hear that much about endocannabinoid. But that's something that is changing in the last years, because we know that also this system might be involved in the onset of psychosis. So I wanted to just tell you a couple of hints so that you know at least that this exists. That's also interesting. A lot of people do not know, that we do have an endocannabinoid system. So that means that even though you never used cannabis in your life, which most of us didn't do, but we do have an endogenous cannabinoid system. So we have a system that resembles a lot to the cannabis stuff that we can find in the nature. So that's pretty weird thing to know sometimes for some people, but that's really true. So we do have kind of receptors, and we have endocannabinoids, so kind of cannabis-like stuff circulating in our body and in our brain. So that's how it is. And that's also important because in the last 20, 30 years, we know that this system, the endocannabinoid system, is really involved in a lot of different biological processes in our brain. And you have to see the system, the endocannabinoid system, as a system that regulates the other neurotransmitters, right? So I told you about dopamine, probably you know about GABA and about serotonin and all kind of monoamines that we have in our brain. So the endocannabinoid system is a system that actually is regulating, is moderating all of other receptors and monoamines. So that's quite interesting, and it's also important to know that this system is actually really, really spread in our brain. That's something that I never knew how important this is. But if you try to tell, for example, how many cannabinoid receptors we have in our brain, these are called the CB1 receptors, right? So you see it here, these CB1 receptors. We do have really a lot of these receptors, but it's quite crazy because we have more of CB1 receptors than those of dopamine, serotonin, GABA, and glutamate together. So we really do have a lot of cannabinoid receptors. If that's important or not, well, it seems quite important system because it's really widespread in our brain. But it's also important for you to know that this system is really huge. So if the quantity says something about the importance, the endocannabinoid system, it's probably quite an important one. And it's also important because this system is involved in the development of the brain. And that's an important point that I want you to know, that so you probably already know, right, that our brain develops when we are adolescent, right? So between when we are 12 until we are like 21 or 22, our brain is still developing, right? So we have this kind of really important synaptic running in our brain, in where our neurons and synapses really get the form that they will get as adults. And in this process, we know that the system, the endocannabinoid system, is really involved in it. So you can understand that if we have young people being exposed to exogenous cannabinoids, so just smoking cannabis, this may have an influence on the developing of the brain. And that's one reason why cannabis might be involved in the onset of psychosis, because it's changing the normal development that the brain should have only with the endogenous cannabinoid. Because if you take a lot of cannabinoids from outside to your brain, you expose your brain with a lot of cannabinoids that probably will change the way that the brain develops. And that's why this theory is also taking into account, and maybe why cannabis is related to more chances to develop a psychotic illness. But of course, it's not only this. I told you already that THC is the bad guy, and that CBD may have kind of antipsychotic properties, so it might help to against psychosis. That's something that also in the last years in research we've seen. If we look at the brain activity in our brain, so we can define several networks, right? These are the networks that are involved in the way that we experience the world, right? In the way that we experience new stimuli, or in the way that we listen or see or process what's happening in the outside world of our emotions, right? So we can define this in several cognitive networks. And what I want you to know, there are some studies in the last year popping up showing that if we give to healthy subjects, if we provide them with THC and if we provide them with CBD, what we see is that the activity in the brain is differently moderated, and that for a lot of these functions, CBD and THC seem to have a kind of opposite effect in the brain. So that's important, because there's different and opposite clinical effect that we're seeing from outside, right? If you use THC, you get psychotic, you get an addiction. But if you use CBD, you do not get you don't get psychotic from it, and you cannot get addicted from it, right? And if we look at the effects in the brain, it seems that also they are opposite. Right? So these antipsychotic properties of THC are also somehow supported by this kind of studies, showing that also the effects in the brain might be opposite. So that's really interesting stuff, and that's something that we also reviewing, and in the next, I think, beginning of the next year, we'll have a summary of this, right? So trying to summarize the influence of CBD in these networks that are also related in the onset of psychosis, and how the CBD may have just a positive effect. Okay, going back to the patient, I also would like you to try to provide a diagnosis, and that's always something that raises a lot of discussion. So let's see what you think. So what happened with this patient? I told you about the addiction, but I didn't tell you how did it work with the psychosis. So let's see what happened. What happened was the following. So the first 3 days when he was admitted to the hospital, with disorganized thoughts and behavior, what we did was actually treat him with lorazepam. So we gave him a benzodiazepine. We didn't start antipsychotic medication. And then what happened is that he could sleep a little bit better. But what we observed, that the disorganized behavior and thoughts actually got worse. So he was not improving, he was actually getting worse. So in the first 3 days, he had to be transferred to a low stimulus area. So we named this a high intensive care. So we have this inpatient unit here in the Netherlands, right, for people with acute psychotic problems. And inside we have another area with it's a kind of living room where the patient is alone with 2 nurses. So he has a lot of attention from our personnel, our staff. And at the same time, it's really quiet because he is a lot. So it's a kind of low stimuli area, right? So that people can just calm and feel better because less stimuli. They're experiencing much less stimuli. And so he had to be transferred there because after 3 days, he was getting worse only with lorazepam. So at that time, at the 3rd day, we decided to start with treatment with olanzapine, right? With antipsychotic medication, and we started with 15 milligrams a day, and 1 week later he started to improve. So after 7 days we saw that he was like calmer, had less energy level. He could sleep much better, and actually his thoughts and his behavior were normalizing. For example, he had, as I told you before, a lot of reference delusions, and these were getting better. So he was able to distance himself from it, right? So trying to say, okay, that's probably not true, that's probably not what happened. So he was getting better and getting more insight in what happened. So then we started psychoeducation, of course. And at the end of the second week, the psychotic symptoms were already in partial remission. So the symptoms were not in fully remitted. So he had still delusions, some delusions, but he was actually quite improved, and that was a reason that we discharged him from the hospital, and he went back to the States together, of course, with his family. So he flied back to the States, right? So then my question for you, of course, pretty obvious, right? He went to America, back. So we have to give him a kind of classification, right? Using the favorite book of the Americans. So if you have to classify this patient using this book, DSM book, which diagnose you think it suits the most with the information that you have? Can we talk about a unspecified schizophrenia spectrum and other psychotic disorder? Can we talk about a brief psychotic disorder? Can we talk about schizophreniform disorder? Bipolar disorder? Is this a substance-induced psychotic disorder, or is this schizophrenia? So please vote. Let's see what you think. All right. 10 people already voted. So feel free if you want to vote, if you want to, I have to lie back a little bit and let you think and vote. Because I'm always pretty fast talking, so maybe you need some time to think about this. Okay, 12 people voted already. Somebody else want to vote? 13. All right.
Maybe for those who just joined this seminar, so I put the polling website in the chat box. Please vote.
All right, wow, it worked. 15 people already voted. Now, great. So I think we can move on. That's something also really fascinating, but because wherever I go, I also see quite a spread differences in the classification that we use, and that's once again why the DSM is sometimes not the best book for to use. But what we see here is that most of you think that this is a substance use disorder. But I like to start why we cannot talk about a brief psychotic disorder. So that's what I want. First, I want to point out. To talk about a brief psychotic disorder, what you need is that, according to the DSM, of course, what you need is that the symptoms that the patient had are in fully remission within 1 month. And in these patients, as I said in the slide, the symptoms were not in remission yet. So we do not know if he will have a brief psychotic disorder. It's possible. So if the symptoms that he had really remitted within a month, which is still possible because now he's like traveling to the States, and maybe the symptoms will remit in the next week that he had, and he recovers the functionality that he had before the episode, then you can talk about a brief psychotic disorder. So at this moment, we cannot diagnose this. The same happens with schizophreniform disorder. So then actually you need a longer period. So people with a schizophreniform disorder, it means that at least they have more than 1 month symptoms and less than 6 months symptoms. So that's why you need to diagnose someone with a schizophrenia disorder. That's not the case, because this patient has been admitted for 2 weeks or 3 weeks, and the symptoms start 3 days before the admission. So he is not even 1 month with psychotic symptoms. So we cannot talk about schizophrenia disorder. And the same happens with schizophrenia. To be able to talk about schizophrenia, you'll need at least 6 months of psychotic symptoms. So that's not an option. And I understand a lot that a lot of you also pointed out that that might be a substance use psychotic disorder. But actually what I did with this patient, I classified them as unspecified schizophrenia and psychotic disorder. And I tell you why I did this. Because the concept of substance use disorder is actually a complex concept, which also raises a lot of discussion. And that's the reason. So if you want to know if a psychotic symptoms or disorder might be the expression of an underlying psychotic disorder, such as, for example, a schizophrenic disorder or a brief psychotic disorder of schizophrenia, then you have to pay attention to this list of symptoms, so to the list of facts. The fact that this patient was admitted, and after 3 days, the symptoms got worse, even though he was not using drugs anymore. That's something that made us think, okay, so probably, it's saying that my internet connection is unstable. Can you hear me still? I hope so.
Yes.
Yeah, okay, I see.
Yes,
If I say,
hear.
so the first thing is the persistence of symptoms with the abstinence. And that's, of course, really difficult to do if someone is already admitted and you are already treating him with medication. But the fact that after 3 days he was getting worse, that's something somehow unexpected. And when you have a really induced psychotic disorder, what you see is that the symptoms actually remit within 1 week. So you would expect that in 7 days, even without treatment, the symptoms will get better or will improve a lot. And in this case, it was not the case, because he was actually getting worse after 3 days. So we had to start the antipsychotic medication because he was not getting better. And after 2 weeks of giving him medication, he was not even in remission. So that's something that made us think that probably, and it's not only a psychotic induced disorder, but it might be also an underlying psychotic disorder. Another important fact is this one, right? The relation with the type and the amount of use. So what you see in this case is something that happened really often in psychosis, is that the patient actually didn't change the amount of cannabis that he was using. So he just kept on using the same that he was using in the last year. So that's something for an induced psychosis. You would expect that the person used less or more, or a new drug or something that may have triggered the symptoms, but it was not the case. He was actually pretty stable using the same stuff in the last time. But change it a little bit maybe is the type of cannabis that he was using, because he moved from the States to the Netherlands. And the Netherlands is also known because we really do have quite kind of high potency cannabis. So that's something that may have triggered the symptoms, but he was already 2 months in the Netherlands and he started using cannabis almost right away when he came. So probably it's a factor that has contributed to the symptom, but we cannot talk to purely an induced psychotic episode. Another important thing is this one, is the family history of psychosis. This is the most important factor of all of them. If you have someone who experienced what it seems an induced psychosis, but it has someone in the family already with diagnosed of schizophrenia or a severe psychotic disorder, the chances that this person has to experience, also to have an underlying psychotic disorder, are much higher. So you have to pay attention. This guy, this patient, he had a family with a bipolar disorder who already experienced psychotic symptoms. So we cannot rule out that for him also might be an underlying bipolar disorder or another underlying psychotic disorder in this patient. We cannot rule this out. These are also, of course, important. Typical symptoms, well, that's less important, I think, but this one is also really important. If you see a patient who's already experiencing negative symptoms or cognitive symptoms, that was not the case in this patient. He was not experiencing this. But if you're someone who already experienced negative cognitive symptoms, then you have also to think about a underlying psychotic disorder. And why is that? I want to point out with this, I only wanted to point out that the classification induced psychotic disorder is a pretty unstable classification. Right? That's something that I want to point out. If you look to studies in the literature following up patients who experienced a psychotic induced episode, you see that the conversion rate, it means that the proportion of these patients who in the future are diagnosed with another psychotic disorder is pretty high. So you can see that between 10 or 40% of these patients after some years will get another diagnosis. So that's a lot. So what I wanted to say with this is if you meet someone who already experienced psychotic symptoms, even though it was a clear relation with the drugs, and you think that it may be a substance-induced psychosis, I would follow this person in the years. So because some of these persons will make a transition and will develop an underlying psychotic disorder. So it's important to be aware of this. And especially what you see from the literature is that those who have a family history, and so someone in the family with a psychotic disorder, are those who have more chances to develop a psychotic disorder in the future. So that's something to take into account. Okay, going back to the hypothesis. I think I will skip a little bit this because I see the time is already 6:11. It's already 11, and I want to talk about treatment a little bit. So maybe I'll skip this a little bit, and I go to the summary of this. If we go a bit in depth with the dopamine hypothesis, that explains why some people may experience psychosis. You see that if you get all the patients with schizophrenia, these are the most common alterations that you may find in the brain when you talk about a dopamine hypothesis, right? Especially the increased dopamine synthesis capacity and dopamine release. These are the most replicated findings that we see in people with psychotic disorders. But of course, if we look at people with addiction, so probably you already have some neurobiology of addiction, so you've already learned that what happens actually is just opposite. So people using a lot of drugs, alcohol or cannabis or stimulants during years, what they experience is just the opposite. So the experience is a decreased synthesis capacity and a decreased dopamine release. But these people also get psychotic, right? So these people may also experience psychotic symptoms, even though they have exactly the opposite findings that you would expect in people with schizophrenia. Okay, so because of this, there are some theories saying, okay, then one explanation that we can have on this is that those with a psychosis without substance use disorder, maybe the most important factors, biological factors related to the psychosis are those related with the presynapse. So it is these factors here. And in those who already are using a lot of drugs, the most important factors involved with psychotic symptoms are the postsynaptic alteration. So the what's called the supersensitivity. So that's the point that the dopamine receptor get kind of another form or another functionality, and this receptor hyperreacts to dopamine. So even though there is less dopamine, the reaction of this receptor is so modified in a way that it may also be involved or contribute to developing of psychotic symptoms, so that the mechanism might be different, right? And then I wanted to show you here a study, that actually supports this theory, but that is just a theory. So I won't spend much time on this because this is just a theory. What happens a lot in psychosis is that after a couple of years, you see that the theories, are like evolving, and something that was true a couple of years ago is not true anymore. So that's why I don't like the details, but I like the bottom line message that I want to give you is that the mechanisms that might be involved with someone in the onset of psychosis might be different per person. So the biological mechanisms underlying psychotic symptoms, really similar psychotic symptoms, might be totally different. I heard like a lot of sound. It was a funny sound. So maybe you gotta mute yourself. Okay, and so the bottom line message here was just this, right? That the mechanisms related to the psychosis might be different per person, and that's pretty weird. That's pretty weird to hear sometimes, because maybe we expect, right, that all people with psychosis, they would have exactly the same mechanisms underlying the psychotic symptoms, but that's actually not the case. And here in this slide, you can see some examples from it. Let's keep on dopamine, for example, and dopamine dysregulation. So I told you already, right, that the most replicated finding in people with psychosis, if we look at the brain using PET scans, we see that these people experience an increased dopamine capacity, right? But is that the case for all patients with schizophrenia? No, that's not the case. If we look at the patients who are not responding to medication, so those we provide them with antipsychotics and they are not responding, and then we look at the brain of these patients, we see that they do not have this increased dopamine synthesis capacity, but they are psychotic, right? So that's saying maybe in this group of patients, in this example, those who are not responding to medication, maybe the mechanism involved in the psychotic symptoms that they're experiencing are not related to dopamine, maybe are more related to inflammation, or maybe these are more related to glutamate or the endocannabinoid system or whatever. So the bottom line message is the underlying psychopathology, the underlying neurobiology from a psychotic disorder, it might be different from patient to patient. So that's why I want to spend a lot of time on this, because you can, I mean, if you invite like someone with a lot of experience in glutamate, he will, talk about 1 hour about the glutamate alterations in psychosis, but that may be only true for a group of people with psychosis. That's the main message I wanted to give you. Before we go a little bit to the treatment, so I like to spend like maybe 10 minutes, something like that. Is that okay for you? 10 minutes or 15 minutes, and then we go to the discussion. Because of course, yes. I like to hear you. Yes?
It's okay.
Okay.
Please continue.
That's fine. Now, I'm gonna sweep a little bit to the most important part, to the most interesting things, what I think about the treatment. And here are some important facts that I really believe. So the first one is that we have to move to an integrated treatment. So what I mean here is that you have to treat the addiction and the psychosis at the same time. So it's not real to like only focus in one aspect, because both addiction and psychosis are actually the same package. So you cannot separate them. So if you are able to try to treat both at the same time, it doesn't mean that you have to do it alone. Of course you can use other psychiatrists more specialized in addiction, or other one more specialized in the psychosis. It doesn't matter, but it has to be a kind of integrated treatment. So it has to be a really good coordination, and ideally you would like to have someone able to treat both. So one person being able to treat both at the same time, that would be actually the best. That's also really important. The goals might be really different. So people with addictions, you know this already, sometimes are really difficult to change. Behavior can also really difficult to change. So you have to keep, of providing motivational interviewing and try to make them understand that what they have, it might be an illness that needs treatment. And sometimes the goal might be retention to treatment. So that means that the person keeps on seeing you. That it seems really weird, but that's actually already treatment. So if you get, I'm talking about the most difficult patients, of course, and those who have psychotic symptoms, a lot of addiction, and these are really difficult to get in healthcare. So sometimes trying to get them in healthcare is already can be already a goal. And of course, what you want at the end is that they change behavior, that they stop using drugs. Of course, that is the main goal, but sometimes not realistic, and you have to start lower and work towards the goal of stopping with drugs. So sometimes you cannot start with stopping, because sometimes the patient is not able to yet, right? So you have to make the process. You always have to discuss the options to stop. And that's also true for nicotine. And that's something that some people don't agree, but using nicotine is never good for you. And a lot of patients, they try to cope with symptoms also using nicotine. And that's something quite accepted, also in the Netherlands, right? There are a lot of nurses and also psychiatrists, they say, nah, it's okay, he's psychotic, let him smoke it's okay for him, it's good for him. No, it's not good for him. So we can't try to lie to ourselves, but that's not true. It's not good for the patient. There are some studies showing that keep on smoking is not good for your cognition. It's not good for your mood. So it's not actually good. It's a coping strategy. It's something that we allow the patients to do, but it's not something healthy. And we have to learn patients to try to cope with the symptoms of a healthy way. So you can sport, so you can do whatever you want, but not use drugs to cope with the symptoms. And nicotine is also a drug, so you can get addicted to. So that's not good. I said it already, the induced psychosis is unstable category and patients in the long term, but this is only for the patients who are experiencing a lot of symptoms that really have severe forms of addiction. At some point, you have to start changing the goal, and the goal is not stopping with the drugs, but trying to avoid damage from the drugs. So sometimes you use harm reduction strategies to avoid patients to experience damage from the drugs that they are using, right? So there are a lot of programs for opiates and that kind of things. And here in the Netherlands, we are also looking if we can start similar programs for cannabis use. Patients with psychosis that are using a lot of cannabis, we want to see if we can use kind of harm reduction strategies, trying to provide a cannabis that is less damaging. So that's also a way to look into this. But of course, these are the exceptions, and these are only the most severe patients. For all of the other patients who experience psychosis and at the same time addiction, the first thing that you have to know is that the psychosocial treatment, the psychotherapy, works. So that's good news. And if you look to the literature, we do have a lot of different forms of psychotherapy. So probably you're familiar with some of them. For example, the motivational interviewing, probably you'll get lessons about this. Motivational interviewing is working already. So if you are able to provide motivational interviewing, you can start already treating someone with addiction because it works. So the good news is all the psychotherapy works. So that's positive message. We have different types and all of them works. And another important thing that you have to do is also this, monitoring the physical health of these patients is crucial, because as I said before, these patients, they do have like a 1.5 to 2 odds ratio of dying. So mortality rates are much higher in people with addiction and psychosis. So it's really important to monitor also the physical health. If you want to know which antipsychotic you should use in people with experiencing psychosis and having an addiction, what the literature is saying is that the second generation antipsychotics should be the treatment of choice. And the reason is that some studies have shown that if the treatment with second generation antipsychotics, it might help better reducing the symptoms. Some drugs may help reducing the craving, and also some studies showing that some medication might also, from the second generation, might also be good to reduce substance use. So that's why the second generation is advised. This is a kind of efficacy list that I made, but I have to say, you do not have to believe this entirely, because it is based on limited evidence. So that's probably that in the future this list will change. But what we know for now, and that's really clear, is that clozapine is still the best treatment also for those with psychosis and addiction. That's pretty clear. So from all the list, what I believe truly is this: clozapine is for sure the number one and is still working the best, also in patients with addiction. And another important things, I don't know if you use this a lot there in Indonesia, is that the use of long-acting injectable antipsychotics. So there's a medication that you provide once, and then so you give one injection once every 2 weeks or every month. And that's another way to administer the antipsychotic medication. And that's something that also some recent literature that we will also publish soon is showing that patients who are who are getting long-acting injectable antipsychotic and actually showing better outcomes compared to those with psychosis and addiction without the long-acting injectables. So these people, they get, for example, less hospitalized, but also the mortality rates are less. So that's like probably saying that the therapeutic adherence to the medication, the compliance to the medication is much higher in these patients, and that's why this medication might also be really helpful in this group of patients. Here you have a table, also an important table, giving a summary of the most recent evidence about the use of anti-craving drugs for the treatment of addiction in people with psychosis and addiction. Of course, this is all only for people with psychosis and addiction, right? So don't be misled. This is for psychosis and addiction. And of course, what you see here, so maybe it's a bit weird for you to read this, but we do have a low evidence level, for example, for nicotine replacement treatment. But that doesn't mean that this is not the first option to treat nicotine use disorder in people with psychosis. Nicotine replacement treatment is still the first option to treat people with psychosis and addiction. The reason that we have low evidence is because there are no studies, there are no good studies in people with psychosis and addiction. They are not published, they are not done, but it doesn't mean that it's not effective, right? So that's an important thing. So we have better evidence for bupropion, for example, and varenicline, because we have the industry probably, like pushing this kind of trials. But the nicotine replacement treatment also works in people with psychosis and nicotine use disorders. So this is, at least in the Netherlands, the first option always, but you can also use bupropion and varenicline to use nicotine use disorders in people with psychosis and nicotine use disorders. With cannabis, we do not have any evidence at all. So we do not have treatment for cannabis use disorder in people with psychosis, right? That's important. Probably you've read this. There's one trial published this year, published in The Lancet, this year, showing that CBD, right, there's the component of the cannabis I told you about, that CBD may help for addiction, for cannabis addiction in people without psychosis, right? So in individuals with a cannabis use disorder. So this study just popped up this year in the Lancet and the Lancet Psychiatry, but we do not have any studies in people with psychosis and cannabis use disorder, right? But we are involved in a really big trial that we want to perform here in Europe, trying to explore this, if CBD is also helpful for people with psychosis and addiction. So we'll know more about this. But at this moment, we do not have evidence we do not have any treatment for these patients. Alcohol use disorder. Do we have medication that may help people with alcohol use disorders? Well, the answer is yes, we do have some. The most evidence that we have is for naltrexone, right? But this, you see here, other medication that we also often use in people with alcohol use disorder without psychosis. And you see that the evidence is much lower. So for acamprosate, we have this negative randomized control trial, so that would be not the best option. But for topiramate, for example, nalmefene is a new medication, or topiramate, we have evidence that may help for alcohol use disorder, but we do not have evidence for people with psychosis and alcohol use disorder, only for naltrexone. And with disulfiram, right, you have to be really careful with the use of disulfiram, because this is a medication that only can be used if the person that's getting this has a really good compliance, because of course it's dangerous. I mean, if you drink alcohol while using disulfiram, you may have a really severe reaction in your body reaction, right? Hypertension, and it might be mortal, even mortal. So you have to be really sure before using this. And we also have some studies. Some case reports are popping out, some case reports showing that some people using disulfiram may also get psychotic symptoms. So disulfiram would not be the first option if you ask me. So I would choose, for example, first naltrexone for craving against alcohol. And then, of course, for cocaine and stimulants, we do not have anything. So that's also quite disappointing, because from the survey, I saw that a lot of you see people with stimulants, use disorders and psychosis, but we do not have any treatment. So that's bad news for you. But I cannot say that we have something that may help these people, unfortunately. Okay, in light of the time, I think I'll skip this a little bit. These are novel approaches, more about cannabidiol, of course, because this is what I do in research and I like a lot. But you can read this at home. We published all the summary in this article here that I'm pointing out right now. And from last year, you can see a nice summary of the use of cannabidiol, CBD, for treatment of psychotic disorders and also for substance use disorders. There's a lot of research going on, but for now we cannot say that works. Important message. So we cannot say at this time that cannabidiol, that CBD, works against psychosis and addiction, but there are a lot of trials going on. So it's possible that in the next years this will change a little bit. That's a possibility. Okay, then I'll move to the conclusion and then we'll start the discussion, so we still have some time. Short conclusion. First thing, I already said this before, but is that the drug use is really common thing in people with psychosis, is rather rule than exception. But you already know this if you're working with people with psychosis. And also the second one is that if you stop using, that improves the outcomes. It's also a really important message I want you to know. So that's something that we can always tell to patients, because we know that if they stop using, they will get better outcomes for everything. So that's good news. Cannabis, as I said before, is related to the onset of psychosis. And especially the younger you start, the more potent the cannabis is, and the more you are exposed to cannabis, the more the odds ratio to develop a psychotic disorder. I told you already that induced psychosis is a rather unstable diagnosis category in a DSM-5. So if you have people with a induced psychosis, but also with family history, you have to suspect that it might be also an underlying psychotic disorder. So you have to follow up these people in a time. And about treatment, just some important facts. Psychotherapy works, right? So that's important. Psychotherapy works, so you also have to provide psychotherapy if you're able to. About a medication for psychosis, we know the clozapine is the best, that second generation antipsychotics should be the first option, and that the compliance is really important. So using long-acting injectable antipsychotics should be also an option for these patients. And I told you already what for anti-craving drugs do we have. So you have a list, and there are some options as well. So you can also think about giving them. And finally, harmful effects. That's for most chronic cases. At some point, you want maybe you want the goal of the treatment will not be anymore stop using, but trying to reduce the harm related to the drugs. And unfortunately, we do not know yet if there exists the cannabis that is safe. Maybe there exists, but it's not for sure the cannabis that we can find here in the Netherlands. You can buy on the street, because it's not safe at all, because it has a lot of THC, and that's what makes you actually psychotic. Okay, so that was my presentation. So I'm happy to take questions or whatever you want.
Thank you so much, Dr. Albert, for the impressive presentations and also your insightful conclusions. So today we learned from Dr. Albert about the risk factors of psychotic break from social stress, which could affect neurochemical system within the brain. And also we learned about the prevalence of substance use disorder and psychosis that higher compared to the general populations. However, cannabinoid also have antipsychotic potencies, and also the age of onset, potency, exposure increase the risk of psychosis. And also we learned that the neurobiology of the relation between psychosis and also addiction are not the same per person. And also the last, we discussed about the treatment strategies that include pharmacotherapy and also the social intervention that are integrated to relieve the patient's symptom. So maybe we have about 25 minutes from now. So for you, who wants to ask questions, please, you can drop your question into the chat box, or maybe you can also ask directly to Dr. Albert by raising your hand, please. And also now we have one questions from Dr. Eduardo. Maybe also you have mentioned earlier that if after abstinence there are still
Oh, yeah.
symptoms of psychosis, for how long are the symptoms thought to be caused by the use of the substance?
Yeah. It's a really good question, Eduardo. Because yeah, that we don't know it for sure. So that's yeah, that's that's quite sad, but that's how it is, because the difference between patients is really huge. So what I said is that in most of the cases, you would expect that if the psychosis is really induced by the drug, you would expect that the symptoms will remit within 1 week, within 7 days. So that's what you would expect in most of the cases. Is it always the case? No, it's not always the case, unfortunately. Most of people will actually remit in 1 or 2 days. So this is the most common situations. For some people, will take to 1 week, but for some other people, it can take 2 weeks and also 3 weeks. So it's quite different. I'm hearing like someone talking.
No, I think.
No?
It's
Okay. I thought that someone was asking. And what I want to say is, if you have someone who's already experiencing psychotic symptoms for more than 1 month, more than 1 month, that is the line that the DSM-5 dropped. So if you're experiencing symptoms for more than 1 month, that's the chance for a induced psychotic disorder 0. So you would not think anymore about a substance-induced psychotic disorder. I hope that gives an answer for all your question.
Yes, thank you, Dr. Albert. So it's different, depends on the substance, right? Like,
yeah, also depends a lot on the substance. Yeah, that's also true, and that's something quite important. That yeah, some substances, especially for example cocaine and stimulants, when they induce psychotic symptoms, they tend to be much faster in remission. So in, like what I said, in 1 or 2 days, almost always they're in remission. And the induced psychosis that I've seen because of cannabis use, they take much longer. So we had this patient here not that long ago. He had a what we thought at the end was a substance used psychosis because of cannabis use, and the symptoms were present for 8 days. So it took 8 days for the symptoms to remit completely. And this patient, he was admitted to the hospital. We didn't start treatment with antipsychotic, so we just gave him lorazepam and started with observation. So of course we provided, a kind of quiet environment and a lot of structure during the day, so that he would just get better. And we saw that in 7 days the symptom just disappeared. We thought started treatment. So then we thought that it might be a substance-induced psychotic disorder. And this patient, he had no family history of psychosis, so it's possible that this is one of these, real induced psychotic disorders. But if this person, the same person, he had, for example, an uncle or a father with schizophrenia or whatever, I would follow this person for sure, at least for a couple of years, because I wouldn't be sure if he maybe had also an underlying psychotic disorder.
Thank you, Albert.
thank you, Dr. Albert.
You're welcome. Good question.
Yes, and also we have questions from Dr. Satya. He asks, does culture influence the comorbidity of substance use disorder and psychosis? Because alcohol use is not.
Really
Yes, alcohol use is not so common in Indonesia, but smoking tobacco is very common. And also he agreed that psychosis and smoking tobacco is very common, and almost 90% patients in mental hospital are smokers. Yes, maybe it's the same with in the Netherlands.
Yeah.
And also, while in general population, around 2/3 of men are smokers. He also tell that meth is easily available here, but cocaine is not. Yes.
Yeah. Okay, really interesting, Doctor. Yeah. Cultural influence is really important. That determines, of course, differences in prevalence in substance use around the world. Here in the Netherlands, also stimulants, it's not cocaine, but amphetamine and especially ecstasy are really popular and more prevalent than cocaine, for example. But in Spain, where I come from, I work now in the Netherlands, but I come from Spain. And in Spain, actually, cocaine is much more popular than ecstasy, for example, right? It's only 2 hours flying to the south in Europe. So the difference is it might be really big in different countries, and cultural aspects are really important. And one of the most important factors that determine how many people in a population uses drugs is also the perception of risk. So if people in a population, they perceive a drug as safe, they will use more. And if they perceive that there are risks related to the drug, they will use less. So that's one of the most more clear factors related to prevalence, and it probably explains that tobacco is so popular, because a lot of people think, well, like tobacco is pretty okay. I mean, you do not die right at the moment. That's true. But then that at the end of your life, you will experience a lot of problems. And I'm also happy to hear the big problem also with nicotine there in Indonesia, because it's the same in the whole world. And that should be actually a priority. Stopping smoking for patients also in psychiatry in general is really important, because these people, they have like 15-20 years less expectancy of life compared to the general population. And that is mainly because of this, because of the use of drugs, because of an unhealthy way of living that they have. So it's also on us as doctors to try to modify this, because it's really big epidemiological and public health issue.
Thank you, Dr. Albert. And also, maybe I just curious that the cannabis use is legal, right, in the Netherlands? I mean, there are a lot of stores sell the CBD. You say that. So, what are the motives?
Yeah, in the Netherlands.
Yes, could you tell us more about that? What is the motive of the users to consume?
To use cannabis, you mean?
Yes.
Yeah. Well, in the Netherlands, cannabis is pretty popular. So cannabis is the most illegal drug used in the Netherlands. It's the number one. So after that, you have the ecstasy, but first you have cannabis. So cannabis is pretty popular in the Netherlands. Of course, after alcohol and smoke. I mean, smoke and alcohol are really popular. The most popular. So you have the most substance use disorder are related to nicotine and alcohol, and the third one is cannabis. And in the Netherlands, it happens something really weird. So they have here a kind of special policy with cannabis. So cannabis is not legal, but you can use cannabis legally in the coffee shops, right? So these are kind of special shops in which you can sit and use cannabis. You cannot smoke. That's also a pretty funny thing, because smoke is forbidden, so you cannot use nicotine, but you can use cannabis. So that's a quite interesting thing. And then you have these places, these coffee shops, and then people is allowed to use there. And that makes cannabis is really popular. And you said, okay, why is actually people using cannabis in the Netherlands? And the most important reasons to use cannabis in the Netherlands are related to the pleasure that you get when you use cannabis. So the high that is associated with it. So that's the most important reason for using cannabis in the Netherlands. But I got to say that once again, so it's also a minority of people using cannabis in the Netherlands. It's not that most of the populations are users. So I checked the service for the last years, and what I saw is that we do have approximately like around 17% of 18% of users in the last year. So in the Netherlands, young people between 15 and 34 approximately. So approximately 18% of these people used cannabis in the last year. So that's probably pretty huge compared to Indonesia. I don't know. But that means actually that most of people, so 80% of the young people, do not use cannabis. That's also the message, right? And from those who used cannabis in the last year, what we see in Europe, and that's kind of worrying, is that the number of people that wants treatment to stop using cannabis, it grows every year. So it's growing every year. So we do see more and more young people having problems to stop with cannabis use. So that's something that's quite worrying, because that's just after alcohol, problems with cannabis is already the second reason to go for treatment in addiction in the Netherlands. So that's pretty huge, right? So that's before cocaine, before ecstasy, and all the other drugs. So cannabis is already the second reason. So that's a bit worrying. Yeah. No. I see also a question in the chat. I think, right? So yes. I read here. May I read this question? It says,
yes.
How do you deal with patients that are having a really hard time on tapering benzodiazepine medication? Yeah, it's a really good question. Yeah, it's a really good question. That's also an important thing. What we do here in the Netherlands is that if we want to reduce the use of benzodiazepines, we do this really slow. So especially in those who experience a lot of problems. So what we would advise here is doing it really, really slow. Sometimes we do, of what the guidelines say is they have to do around a 25% reduction of the dose per week. But sometimes I go even slower. So sometimes it takes months to stop with benzodiazepines. So I got this woman here in the Netherlands. I was treating her because of psychotic depression, and she was using lorazepam for more than 10 years, 4 milligram lorazepam for more than 10 years. And she developed also an addiction to lorazepam. So it took me around 5 months to stop the benzodiazepines, right? So it took a lot of psychoeducation, a lot of motivation, a lot of skills and patience to be able to stop, but it worked. So at the end, is also the message. It might be really difficult. It might seem impossible, but it's possible. So if you take the time. It took me 5 months, but I could stop all the benzodiazepines, as she's not taking benzodiazepines anymore. And of course, now she knows from me that she will never get a prescription again of benzodiazepines. Yeah. So go slow. That would be my answer.
Yes, thank you, Dr. Albert. And also, there's one question that asks about which components related with pro-inflammatory status, THC or another components of cannabis?
Yeah, good question.
Yes.
Yeah, really good question. What we know from the literature is that CBD, right? So the cannabidiol, the CBD may have actually anti-inflammatory characteristics. So the CBD may help against inflammation, and that's one of the mechanisms that we think that it might be involved in the antipsychotic properties of CBD, because it is just anti-inflammatory. But about the other components, I can only talk about THC, and THC has more pro-inflammatory characteristics. So it's not anti-inflammatory, but more pro-inflammatory. And about the other cannabinoids, there are like more than 100. I don't really know. But the other cannabinoids are much less studied. So you have like cannabidiol, for example, and a couple more that are being more and more studied in the last years. But THC and CBD are the two most relevant components in the cannabis plant. So that's why these two are most studied in the world. So about the inflammatory properties of the other cannabinoids, I cannot tell you that much. But we know that CBD, and that's quite interesting. It may have anti-inflammatory anti-inflammatory properties. So that's why it's being explored also for really different indications, and not only in psychiatry, but CBD is also being explored, for example, for neurological disorders. So there's a lot of research going on in epilepsy, for example, or in other neurological disorders because of these properties of CBD.
Okay. Thank you, Dr. Albert. And maybe it's the last questions. Maybe, is there anyone who wants to ask questions directly to Dr. Albert? We have 5 more minutes. I think that's all. Thank you. Yes, thank you,
Nice.
Dr.
Otherwise, if you have more questions, you can always mail me, right? So I think you have the slides, you see my email. If you have some questions, you just feel free to mail me. I'm happy. And it was a pleasure being here. Thank you a lot for the invitation, and you all for your attention. It was really nice.
Thank you. Thank you very much for a great discussion today, Dr. Albert. And also, yes, maybe I will turn our mic to Dr. Evelyn.
Sorry?
Yes,
Okay, thank you. Thank you, Dr. Dorothel Ikrimah, and also thank you, Dr. Albert Batalla, for the interesting discussion. And today is the last day of our second online seminar series. And to officially end this program, we are pleased to have Dr. Fasuryani as a psychiatrist and lecturer of psychiatry and human behavior at Atmajaya, and also chairman of Indonesia Consortium Addiction Technology Transfer, to deliver the closing remarks. Please, Dr. Eva.
Okay, thank you, Dr. Evelyn. Dear Albert, colleagues, I believe that during this second online seminar series, all of us have obtained a fruitful discussion. In this second online seminar series, we have discussed about CBT and psychosis and addiction. Many people with mental health issue use substances, and in people with psychosis, problematic drinking and use of illicit drugs occur more frequently than in general population. Understanding of the link between psychosis and coexisting substance use would greatly facilitate the development of treatment approaches. One of the treatment that we have discussed is CBT, which is believed has a main role and superior compared to other psychotherapies. The goal of CBT itself are to train patients toward more adaptive thought patterns, strengthen their impulse control, and help them find healthier ways to cope when things get tough. I hope that you have learned through this topic will help you a lot in your role as a psychiatrist, GP, and health worker in the future. I also want to thank Albert Batalla Cassis, MD PhD, for taking time out of your busy day to share your expertise with us, and also thanks to Janika Hetman PhD for the previous topics. The information you all share was very enlightening. We hope it was a positive experience for you as well. I apologize for any shortcomings during this online seminar. And finally, I would like to close my remarks and officially announce the end of this online seminar series. Thank you for your participation in this online seminar series. I hope we can meet again in another opportunity. Thank you all, and I would like to give it to Dr. Evelyn again.
Thank you, Dr. Eva, for the wonderful remarks. And finally, we come to the end of this event. Thank you very much for your participation in this session. I hope you enjoy the program. And in the next 1 minute, I suggest to all participants to turn on your camera so we can take our photo together after I finish reading some last information for you. Okay, here's the information. So the post-test link will be shared and copied to the chat room. And we will wait for another 2 minutes for you to click the link and fill the question. And then also e-certificates are only given to participants who has filled the registration and pre-test before each session. And also post-test with pass limit value 80, and it can be repeated if you haven't reached the pass limit value. And the post-test will be closed at 12 a.m. midnight, West Indonesian time on each day. And once again, thank you, Dr. Albert Batalla, Dr. Eva Suryani, psychiatrist, and colleagues for attending this lecture. Now, let's take our photos together before we end this video meeting. Okay, 1, 2, 3. Okay, thank you all. I hope we can meet again in another seminar session.
Thank you.
Thank you all.